Hanging in there? I didn't hear you. How you doing? Oh, excellent, excellent. Glad to hear it. Well, we're going to kind of switch gears a little bit here and tell you now about some ongoing, some new, some novel research in Parkinson's in both the clinical realm and the basic science realm. And first, we're going to start off with Andy Duker, who you all know, who's going to give us kind of a snapshot of research on clinical developments. Andy?
Thank you, Kim. That last one was tough, right? So this task switching, I tell my patients, you know, that one of the big things that you have trouble with in Parkinson's disease is doing more than one thing at the same time. Executive function, multitasking. And so doing that and exercising with that is exceedingly hard, but it really exercises your brain. I think it's a really good workout, both physically and mentally, so well done. All right, well, so I wanted to, this is one of the parts of the program where we're kind of let you know what's going on in research in Parkinson's disease. What are some of the new things that have been published over the last year? What is the future of the field? What's newly approved and available now? Those are a lot of the questions that people often have. You know, clinical research in Parkinson's disease has been progressing, you know, at a very rapid pace. Just as one example, over the last 4 years, there have been 7 new medications approved for the treatment of Parkinson's disease. 7. I mean, you know, in terms of clinical development, that's huge. And so now, not all of those medications are right for any specific person. Some of them are new versions of medicines that we have already in our armamentarium. However, this goes to show you the amount of energy and the amount of effort that's being already expended to improve Parkinson's care around the world. So to touch on that fact in terms of new medications and research that's published in 2019, there is a newer medication that many people have questions about. Actually, I had a question in the patient questions about what is this inhaled levodopa. So inhaled levodopa was approved in less than a year ago in December of 2018. And it was approved for the treatment of off periods in Parkinson's disease. And so if you can imagine, remember that carbidopa-levodopa is one of the main medications that we have for the treatment of Parkinson's. Levodopa changes into dopamine in the brain and helps to replace dopamine that your brain is not making. That helps with the movement, with the motor symptoms of Parkinson's disease. And so it's one of the most effective medications that we have. However, when you take it in its oral form, you have to get it into your mouth, get it into your digestive tract, get it into your stomach, get it into the duodenum and jejunum so that it can be absorbed and then into the bloodstream so it can get to the brain and then have its effect. One of the active areas of research is finding ways to bypass some of that to get that into the system a little bit quicker and maybe more effectively. Inhaled levodopa offers the opportunity to potentially do some of that. So you can see the picture there of the way that it's set up. There are capsules that are put into the inhaler, and once it's inhaled and it clicks, you inhale the levodopa. Its effects are identical to that of oral levodopa. It's the same active medication, but it's just being delivered in a different way. Some of the side effects, as you can imagine with an inhaled medication, could include things like cough, or nausea, dyskinesia. These are mainly, except for cough, of course, the side effects that you see with oral carbidopa. What does the research say? So I don't usually put graphs on these because I think they can be complicated and difficult to understand, but I thought that this was helpful. You can see in the graph there on the right, there were 2 dosages of the inhaled levodopa. The blue line, the bottom line, is 84 milligrams of the inhaled levodopa. The green line is 60 milligrams, so a slightly lower dose. And then the dotted black line is placebo. And so the reason that I put the graph up there is you can see the rapid improvement. Lower scores on the UPDRS indicate improvement. And so you can see from 0 to 10 minutes, there was a quite steep decline, in other words, improvement in the motor scores and the movement abilities of patients in the study. What I wanted to highlight to you, which was one of the things we were talking about earlier, the placebo effect. You can see the dark black line there drops dramatically and almost, I mean, it's a little bit separate from the the study arms, but not very much. And actually, statistically, it's not that much different. If we could harness that placebo effect, that's one of the ways that we'd like to help treat Parkinson's better. But you can see that as time goes on, the oral or the inhaled levodopa gets into this system, and there is definitely an improvement even over and above the placebo. So even though there was this huge placebo effect, the medication actually improved things over and above that. So it is an effective medication. It's not more effective than oral levodopa, but it offers us the ability to treat off episodes in Parkinson's disease at potentially a more rapid phase. It's different for each person, and an alternative mode of administration. Interesting, at 60 minutes, 58% of patients were in an on state in 60 minutes. So that tells you that 40% of patients, even at 60 minutes, were not yet in an on state. And so this isn't necessarily a magic medicine that's right for everyone, but it's an option that we have now. What about other modes of administration? So we're talking about bypassing the gastrointestinal tract. What about delivering medicine subcutaneously, like an insulin pump? Well, they're working on that for levodopa, although levodopa is a very hard chemical to get in through the skin. So that's still not ready for prime time, but it is being researched. Some of the research is being done here at UC. But this is another study that was published in the last 12 months since we last met on subcutaneous apomorphine. So apomorphine is a dopamine agonist. It's a chemical that fits into the dopamine receptor and has a very similar effect to dopamine. And so this was a study in Europe, actually, where they enrolled patients with motor fluctuations, on and off fluctuations, and they were able to reduce the off time by 2.47 hours per day, compared with placebo, which was 0.58 hours per day. The side effects of apomorphine were similar to the side effects of a lot of other dopamine agonists, namely pramipexole or ropinirole, rotigotine. They can cause nausea, drowsiness, but sometimes hallucinations and psychosis, and so those are things that you have to be aware of. However, the idea of a subcutaneous pump is something to help to reduce the on and the off fluctuations is certainly enticing. So the take-home point for apomorphine, there is a study ongoing in the US. It's nearing completion, and if it's approved in the US, it may be another good way to help treat motor fluctuations in Parkinson's disease. All right, a very interesting study was published just this year on the effect of levodopa and whether it slows the progression of Parkinson's disease. So just to back up a little bit, in the past, there was a strong belief, and actually it's still out there, that levodopa, the main medicine that we use to treat Parkinson's disease, is harmful to the brain. And in fact, in cells in a petri dish, there were suggestions that it could have an effect, a detrimental effect, a bad effect on those cells in the petri dish. However, in 2004, there was a study that actually looked at the effect of levodopa on Parkinson's disease. Actually, it was the first study that was done on levodopa because it was a generic medicine. No one had ever felt like it needed to have a study before. But in 2004, it showed that levodopa did not hasten the progression, did not make the progression more quickly over the course of 40 weeks. And so that really put to bed in all of our minds that levodopa was harmful for patients. However, in that study, it did show that maybe it was even helpful. The people who had been on levodopa for 40 weeks actually were doing a little bit better than those who had not. And this was after washing out of the medication. So there was a question in people's minds, could levodopa slow the progression of Parkinson's disease? So this trial, the LEAP trial that was just published, was done in the Netherlands, used a newer study design called a delayed start study design to try to figure out, does levodopa slow the progression? And so they looked at people, had them be on placebo for 40 weeks versus levodopa for 40 weeks, and then everyone was on the study drug or on levodopa for the next 40 weeks. And so that's a much more powerful study to design to determine whether it slows progression of the disease. And ultimately, it did not. Starting levodopa earlier didn't really slow or hasten the progression of Parkinson's symptoms. So I think that Ultimately, the levodopa is something that is extremely effective for treatment of Parkinson's disease. It should not be held back on because you're worried about it harming things. However, it doesn't slow the progression of the disease either. It really is a symptomatic therapy. Interesting, another finding of the study was that starting levodopa earlier, one of the thoughts is I need to hold off on this medication because if I start it earlier, I'm going to get side effects like dyskinesia or wearing off or motor fluctuations. Starting levodopa earlier did not hasten the progression of those symptoms. And so, again, another reason not to hold back on the medication if you need it. Deep brain stimulation, we had a talk on that, on how DBS works. There was a study actually published by our center looking and analyzing data from DBS stimulation studies from patients with Parkinson's disease. And what we found was that DBS improved motor function within the 5 years that was studied, as well as after 5 years. So it's a long-term effective therapy. And we knew this from our clinical experience, but this helped to identify that. The interesting part of the study was that we found that the effect of DBS was more powerful when medication was on board. And so when people were studied without medication but with stimulation on, and then compared to when they had the medication in their system, obviously they did better. And so when people have surgery, sometimes the suggestion is to lower their medication too aggressively. And what this study helped to identify is that we don't want to do that. We want to maintain the best possible function. In doing so, we need both the medicine and the DBS surgery. And finally, the last study, actually this touches a little bit on what Dr. Jacob was talking about. This is a new study, and actually did have an arm where they studied yoga and actually a specific kind of mindfulness, specific kind of yoga, mindfulness yoga. And they compared this to stretching and resistance exercise training. So they did have an arm where they compared it to people just doing exercise. And so mindfulness yoga is a combination of yoga and kind of what we did with Dr. Colapietro today. So they did both stretching or yoga exercises and then also some mindfulness exercises for 90 minutes. And the take-home point is really that both of the types of exercise improved pretty much equally the motor symptoms of the disease. And we know this. Exercise has a profound effect on the movement and the motor symptoms of Parkinson's disease. And they were both equally as good at doing that. However, there were some benefits in the mindfulness yoga group in that there was a decrease in anxiety, a decrease in depression, and an improvement on some quality of life scales as well. So I think the takeaway is that mindfulness yoga is a good example of exercise that can help Parkinson's disease, and it may have some beneficial effects for anxiety and depression. We are actually going to have a mindfulness yoga class at the UCG&I building. And that's something that is going to be starting in the fall. And so more updates will be coming on that. So to summarize what we've gone over from the clinical research, and just by the way, these slides are going to be available online as well as the videos on the website that's in the program. Probably beginning of next week or so, they'll be up there for you to peruse. But the summary is that inhaled levodopa is an effective treatment for OFF symptoms. The apomorphine infusion is a newer type of therapy that may help with motor fluctuations, but you need to monitor for side effects. Levodopa, the most important medicine that we have for Parkinson's disease, doesn't slow the disease, but it doesn't hasten the progression either, and it should be used when it's needed. The effects of DBS and medicine together are greater than either alone. And mindfulness yoga is an example of an exercise that can improve anxiety and depression as well as quality of life. All right. Thank you very much.